So this session's going to be recorded, so you have to really behave. So the QR code, just before I introduce myself, the QR code takes you to an assertiveness, an evidence-based assertiveness scoring app. So a standalone, it gives you a percentage and tells you the higher it is, you're more assertive. There isn't any value in doing it once, it's more about tracking your assertiveness. So I did a piece of research across 15 HEIs with specialist practice district nursing students, and a focus on leadership and challenging situations, you can have a statistically significant improvement in your assertiveness. So my presentation's a bit around that. The link to wound care is that we need to be assertive in our practice to have the best outcomes for patients. So I'm Professor Julie Green, and I'm a Professor of District Nursing, and I'm Head of School at Keele, and this is not my campus, it's the campus at Keele. And my background and the reason I'm here with Ellie is that I developed a quality of life app to be used with patients, and I've done some work around using self-evaluated quality of life scores to dictate consultation times and involving the patient in the consultation. So that's my background. Today I'm going to talk to you about the need to be assertive in your practice to get your best outcomes for the patient. So this is the third time, I'm getting faster each time, so I'll slow it down. So by the end of this session, you will understand human factors, you will understand assertiveness and incivility and the impact that they could have on patient care, and hopefully some strategies to prevent that impact on patient care. You'll also see how it impacts on patient safety and how also on your patient and your colleague well-being. And you'll get your own personal assertiveness score at some point today when you fill that one in. Nobody else sees it, you will just get a percentage score. The value is repeating it over time. And what we did see in the study, if you have a particularly challenging, personally assertive experience, often you see a dip in your assertiveness score, but then it does pick up afterwards. So if you've been particularly challenged by something, you may see a little bit of a dip. But what it did prove is that you can improve your assertiveness. You may not think you're an assertive person, but it is about strategies to communicate well. And the reason that we need to is around human factors. So I did some work with somebody called Debbie Rosenhorn-Lang, and she published a book about human factors in healthcare. And she started that session and said to my district nursing students at the time, what for you is a good day? And they said, being able to go to the toilet when I want to and having a lunch break. And we sort of explored that and said, so it's by custom and practice you don't get a break. And it was seen that if you did have a break, that people sort of looked at you and thought, hey, you've got time to have a break, have you? And Debbie talked to them and said, you're actually doing that to get through your list of patients, but you're actually much higher risk of damaging and causing harm, that you're distracted by a full bladder and that your blood sugar's low. And you're not actually doing something positively for your patient's safety by being constrained by the pressures of the team. So it was really interesting getting people to talk about what for them is a good day, what is a bad day. And I think we very much in the NHS have quite a negative approach. I was talking to somebody earlier and they've got a thing, what were the 3 positive things that happened to you on this shift? And they said, couldn't we do the negatives? Because people just see that as so much easier. But the positives may be just little nuggets that you've improved something for somebody, that bit of positive feedback, somebody smiled who doesn't normally. But we tend to always within our teams have that mood hoover there is an approach of negativity. So when we talked about what's a good day, people did talk about their team and great team working, but also the peripheral stuff that sits around that. So whether your kids behave before work, whether you got the dog back when you let them off that morning, whether it was good weather. And I think that's particularly important in district nursing, isn't it? Going to the patients with impaired hearing that you've been stood at the door for 10 minutes and they come and let you in and say, is it raining? And you're absolutely drenched. So weather is very important in district nursing, traffic jams, getting good patient feedback. But interestingly, the bad day was some of the opposites of that, but also staff conflict. I do a lot of this work with neonatal nurses and critical care nurses who look ahead at off-duty. So they might be off for a few days and they'll look and say, oh God, that looks an awful shift when I go back. And we worked with them to say, you can't change who you're working with, but better not to know. Because why worry for your 2 or 3 days off that you're going back? Yeah, and they're almost preempting it's going to be awful. You might as well arrive on the morning and think, oh, that looks a bit dodgy, rather than think on your days off. But other things, But I think what it reveals is that your good day or bad day isn't just work, it's the stuff around work. And we need to look at the positives. It's within our gift to think of what the positives are that day, rather than that focus on the negative, and to encourage our patients to focus on the positive. So Debbie's book, I was advising previous groups. I wouldn't necessarily advise buying it, but it's probably only about a couple of pounds on Amazon, because they always have those regenerated books that have been returned. But she stated that we harm 1 in 10 of the patients that we have contact with in the NHS. And that isn't overdosing them, it's not incorrectly setting up a syringe drive, or it's not the wrong ventilator settings. It's our softer skills. We don't communicate clearly. We don't make sure that the patient has literature that's appropriate for their reading age, that they understand. And my big interest area is self-management, and whether I've got a PhD opportunity advertised at the moment to look at how do we determine who can self-manage safely, because the NHS is really pushing out self-management, and it's not appropriate for everyone, or not at the same level, and how would we assess who that is in a team and support them? But knowledge and competence are not enough, and fatal errors can and do occur. I think within wound care, fatal errors do occur with sepsis and things, but often deteriorating wounds, not really listening to the patient's quality of life needs. In critical care, in neonatal care, fatal errors occur more often, and we've seen examples of that recently, haven't we, with the recent Lucy Letby case. So I think it's getting our head around that it's non-technical skills, it's these things: communication, leadership, team working, task management, decision making, situational and risk awareness, error management, and a systems approach to safety. They're the things every day that are important to keep your patients safe. If you're the leader of that team, who you're allocating visits to, who's got the appropriate skills for that visit, is it equal across the team? All of that leadership is really, really important, and that keeps our patients safe. And we're better at this if we're assertive while we do it. So that's how the link is. It's a tenuous link, but it's the link. And assertiveness, not everybody's assertive, or you may be assertive in certain situations. So I can get a refund on anything. I can become assertive in Marks and Spencer's taking something back, whereas performance managing somebody is far more challenging. So, but it is about being clear, having clear communication, and setting out those boundaries so that everyone's aware. Yesterday I had a health and conduct meeting, and we removed a person from the course, and that person had quite severe mental health problems. And the decision and the outcome was exactly the same. The delivery of that decision is what varies, and for me, kindness is important. So we may have people that we need to manage, but it is how we do that to enable them to look at what, whether that's moving somewhere else, improving their skills. It's how we deliver that, and that's what assertiveness underpins. So it's an interpersonal behaviour that you can grow and develop. It maintains boundaries in relationship, respects others, and it ensures that everybody's views are valued. So you're not imposing yourself on somebody, you're having a dialogue and you're listening. And the listening is really important, because often, if you really think, you're listening for a gap so that you can speak often in dialogue, whereas you should be listening to hear, not thinking ahead about what you're going to say. And it's quite interesting in conversations, if you think, often you are just thinking, when they shut up a bit, I'll say this, rather than thinking what they're actually saying. So all views are equally important, and that's really important. The solution may be different, but people's views are equally important. So it respects the rights, thoughts and feelings of others. It's invaluable for professional practice, improves job satisfaction, manages stress and manages bullying. Because if you are assertive and will challenge, you manage bullying, because you won't receive it, but you also won't allow someone else to bully. So enables safe professional communication and a sense of personal empowerment. You're not going to get it right every time, and it is personally challenging. I think assertive dialogue is very challenging if you think of how you would feel if you were the person approached. And I encourage students not to put themselves in that person's place. because often you don't know how they will react. I think we overthink and think, God, they're going to cry, they're going to be, really upset, and often people aren't. It's about you being clear. And I was telling the last group about, we had a student that had a real body odour issue, and we'd had loads of complaints about this pre-reg student from patients in recovery, just that she was smelly and they didn't want to be cared for by her. And we got the personal tutor to speak to her, and she was so worried and saying, I'd be devastated if somebody told me that, I would be traumatised. She spoke to her and she said, well, hard luck really, I muck out my horses on the way to work and that's how it is. It's not going to change. And we removed her from the course through health and conduct. But I think putting yourself and thinking, I would react like this, actually stops you from challenging, because not everybody reacts like that. And for some people, they're quite hardened to it. So it's really important for professional communication. That's what sits behind the app. So there are 28 questions and it will give you a score. The higher percentage score, the more assertive you're deemed to be. But it's more about how you track your score over time. And if you're relatively low, so an average score would be 50 to 60, very assertive score would be 90 plus. But you can improve your score. So if you've got that and saved it to your home screen, it's there, nobody else sees it, you can just repeat it at any time. And it is evidence-based. So if you're thinking about how you would communicate assertively, so assertiveness takes responsibility, takes the initiative. So if you know something's going on, you will raise it because you're taking the initiative. It listens, so like we said, it listens, it hears, it speaks up, is direct and constructive, shows sincerity, presents the solution. So I was talking about allocation of visits, and what we tend to do in the NHS, if somebody's not very good, we give them fewer visits, or not the complex visits because they won't manage. And really that shouldn't be the case. Everybody who's there at whatever grade should be working to the performance, of that grade. And we should be challenging. I was a burnt out ITU nurse at the start of my career, always had 2 patients on every shift, and was in a situation, it was a toxic environment, you would never have raised concerns. So I left. If we don't address things, and at the time I was quite a naive early career person, I wouldn't have challenged. I wouldn't have said I didn't know what I was doing if it was a new syringe driver, because I was too scared. And that's when patient harm occurs, because you're in an environment that you don't raise issues. So it shows sincerity, it's solution focused, confident voice and body language, addresses the concern to the source is really important. You don't talk to your colleagues about it, you take it to the person. Because otherwise we end up with teams that are uncomfortable for people to work in. And it says what you need. So when I was always allocated 2 patients, I should have gone to whoever was allocating patients and said, this really isn't fair, I can't cope with it. But you don't. So you may have team members who you think, oh, they're wonderful. They'll rush through all those visits, they'll be great, and they're clinically very sound. But is that fair to that person that they're taking their lion's share of the work? So this is what we want to be. And we want to avoid this, and we will all have worked with people who are aggressive. So blunt, harsh in tone, they blame and browbeat, they push for their own way, and it's a one-way conversation flow. Whereas assertive people are very different. So they are direct but firm, they collaborate on the solution, they speak up and listen, and they hear the other's opinion, and it's a two-way conversation flow. This is where people function at their best, and if you are that leader, this is how you need to instill in your team they need to behave. And often it isn't. I've worked in many places that you would reflect it's not been a comfortable place to work. And I think in bigger teams, so the intensive care unit where at my neighbouring hospital has 400 staff, and that breaks off into small groups, and it isn't a particularly nice place to work. And I think similarly in community nursing, we have merged lots of teams into bigger teams. Often people keep to their team because they know them, and that segregates the team. This study is really interesting. So a study that called Silence Kills in 2005, and it hasn't been repeated. It would be really interesting to repeat this. 1,700 nurses, physicians, clinical staff and administrators, they said it was common for providers to say nothing when they observed troubling performance by colleagues. 62% of nurses saw co-workers taking shortcuts that may endanger patient care. 48% of nurses believe that co-workers show poor clinical judgment, but fewer than 10% of nurses, physicians and other clinicians ever confronted their colleagues. And I think if you think that possibly is still going on today in many teams. I don't know whether the percentages may have changed a little bit, but I think it is still an issue within teams. The other things it found, 77% of nurses work with others who are condescending, insulting or rude, 33% work with a few who are actually verbally abusive, and 88% of nurses have one or more teammates who gossip or are part of a clique that divides them. As a leader, you have to make the situation that people can raise concerns and you protect those people. And I was using an example. So when I was district nursing, I had an enrolled nurse called Sylvia who daily bent the rules. So Sylvia would always give visits back, however many, and we'd give her fewer visits because she never finished them. And she would, so I had a healthcare support worker one day that said, she did a double-up visit at 3 o'clock, a 15-minute visit, and they were about an hour and a quarter coming back to clinic. And I was like, oh, was it particularly difficult today? And Sylvia had said, oh yeah, we had to almost bed bath him, it was complex. And then later, Pat came to see me and said, I've had an awful experience. Sylvia said after we'd finished this double-up patient, I'm going to pop and get my grandchildren from school, nip and get them through a drive-through, and then pop them at home. So that's what they've been doing. So Pat came to see me later and said, I had an awful time. I didn't want to be there, but I was in her car, I couldn't do anything. And she very much perceived she was the junior member of staff, that she couldn't raise concerns. But she wanted me to address it, but not to say she told me, which is always one of those dilemmas. So I thought about it, and so I did approach Sylvia and said, actually one of the relatives of a patient has seen you queuing at, I thought that was a really genius idea at the time, you've been seen queuing at McDonald's and you were an hour late. So I protected Pat but acted on those concerns, because you have to be seen to act if you're a leader. You can't just say, oh, let's let it go. I had another incident where the same person must have gone and had her hair done at lunchtime, and she looked like Cleopatra in the afternoon. She didn't look like that in the morning. And I was looking at her and said, oh, Sylvia, your hair looks nice. And she said, I've just had a wet cut at lunchtime. She had not just had a wet cut, it was a colour and whatever else. But there will always be those people that bend the rules. Often they've been there a long time, but you've got to challenge, else you lose your credibility with the team. So Sylvia retired, she's happily retired, I'm sure. And incivility moves on from that. So I've been doing a lot of work around incivility, which is just those people that don't treat you well. So there isn't a single definition of incivility, but it can be anything from eye-rolling sarcasm to actually gossip, exclusion, and even physical aggression. But none of it is minor. So if you were in a team situation, you give a suggestion or something, somebody always rolls their eyes or tuts or something, that is incivility, and that is putting you on the back foot, not listening to you. So it leads to poor teamwork, high turnover, and increased rates of patient harm. There's a wonderful TED talk on incivility, and it's in an emergency department, and it links incivility with poor patient outcomes. This poster you can download and print and pop in your team area, but it says incivility, the facts. What happens when somebody is rude? 80% of recipients to that rudeness lose time worrying about it. 38% reduce the quality of their work, 48% reduce their time at work, and 25% take it out on service users. Less effective clinicians provide poorer care. And the thing that was enlightening to me was people that witness it. So in a team environment, if somebody is incivil to somebody, the people that observe that, 20% decrease their performance, 50% decrease their willingness to help others. And if you're in an environment where service users observe that incivility, 75% are less enthusiastic about that organisation. So it has huge effects. Incivility affects more than just the recipient, it affects everyone. And there's this campaign, Civility Saves Lives. And it may be something trivial, it may be something that you don't feel is something that you could raise, but it does wear you down. So we're supposed to be in the most caring profession, often it isn't. Kindness is key, and the delivery of a message in a kind manner is important. 27 to 85% of nurses experience some form of incivility, and I think if you think back across your career, there won't be one person who hasn't been the recipient of incivility, and that could be top down, bottom up, equal people in terms of the hierarchy of grades. It doesn't matter, it's being the recipient of it. impacts on mental health, it decreases job performance, and it does lead people to leave. You lose good people because of incivility, and it impacts on patient care. So more likely to deliver poor patient care and risk patient safety. Ooh, sorry. I'll send it, I'll ask Ellie to send it round. Do you want me to go back to that last one?
No,
you're right.
Thanks.
So in terms of psychological safety, if you are a leader of the team, we want to make sure our team is psychologically safe, and that means that somebody can have an idea of how things could be better and they will be listened to. It doesn't mean you've got to do it, it means that they feel safe to raise it, have it discussed and debated, and even if you come back and say actually it wouldn't work, that's fine. It's that feeling valued enough to be listened to. And sharing ideas. It's associated with improved team working, workplace creativity and team performance. Psychological safety is vital within healthcare. So if you are that leader, you need to have a safety culture where people feel safe to come and say, this isn't working, this isn't fair, this isn't right. I went to see a specialist practice student and did a tripartite visit in a really big open office, and at the other side of the office there was somebody allocated to do triage on telephone triage. So as she's talking away, I'm speaking to the student and she said, oh God, here she goes again, telling him a load of rubbish. Whatever she tells patients, she hasn't got a clue. So I said, okay, have you challenged her? And she said, it's nothing to do with me, I'm not her employer. And that's really important, that we have to challenge. The next slide states the standard you walk past is the standard you accept. If we don't challenge, that became your standard. So it's really important to take responsibility. And if you go into somebody's visit and the dressing's not on correctly, or they've got a tourniquet effect, or the patient doesn't understand what they're doing, we need to address it, not compensate for the other person. So we need a leader who has integrity. So you need to be that person as a leader that you can signal to everyone else that they are in a safe environment, that you take professional responsibility. So if they speak up, you will act, you will do something if it's appropriate to do so. That's a learning culture. We're all learning. You know, every day's a school day, isn't it? There's always something we can learn. And I think even as a leader, it's fine to say, oh, I didn't know that, or that's, you know, I'll read up about that. It's fine. Because then I think it encourages other people to think, well, I don't need to know it all. Because, you know, even leaders don't know it all, and nobody knows it all. Have a change-orientated leadership, so you are open to doing things differently. If somebody can come up with a solution, I've just had a student, an apprentice, nursing associate to registered nurse, shortlisted for loads of awards, including parliamentary awards, and she developed a system for managing emergency department patients more effectively. And she worked in a trust and they listened. They didn't say, well, what would you know? You've been a healthcare and nursing associate and you're still doing your training. We don't want to listen to that, but they did. And they've implemented it, and it's really been positive. And she's had, you know, real recognition. She's actually going to speak at our award evening for qualified staff, because she's taken, you know, it takes a lot to put yourself out there and suggest something, and it's been taken on board. And I really felt when she did all of this that nursing is in safe hands. I think you always sort of look at student workforce and think, oh, you know, there's a lot of work to do there, but they are great students coming through, just like they were when we trained all those years ago. Organisational leader and peer support, so a respectful culture, and then that familiarity between team members. So has anybody heard Tommy Whitelaw speak? Tommy talks about dementia and the management of his mum at end of life. But he talked about the importance of knowing what matters to your peers. And he spoke about a dysfunctional team where they'd not really spent any time together through COVID. They were working pretty much remotely, and they just weren't functioning well. And they brought them all together in a room, and they didn't know each other. It was evident that they'd never really knew who was married, who had elderly parents. But what he was saying, if you don't know what matters to your team members, you can't put that extra support in. If you know somebody's got a parent at end of life, or you know, a child that's struggling at school, if we don't know, you have to make allowances for people. So one of the students has actually got, he does it on a tree, but people put post-its on about what matters to them. And I put one up at work, and people put photos of who mattered to them. But if you don't know your team, you can't build your team, you can't support them. And there are times in a team that sometimes coming to work is the best bit of the day for some of your people within a team. And as a leader, you need to be able to support them and know what's going on. So I always encourage people, what matters to you, have it on a board in a clinic, and know who in your team, what matters to them. And Tommy is wonderful. You can watch Tommy's talks on YouTube. But he uses this statement. If you Google David Lindsay Morrison, it was actually in the forces, and he overheard a lot of servicemen, I think it was in the Navy, they've got a lot of female Navy people, sailors, that would be it, and they were really misogynistically talking about these women, and people were joining in, nobody challenged it, and he actually challenged, and this statement comes from his presentation, the standard you walk past is the standard you accept. And I encourage students to challenge, and that's really hard when you're a student because you perceive yourself to be bottom of the pile. But if you see something, you have to challenge. The actual app that you've got in terms of your assertiveness came from a study by somebody called Warland in Australia, and they had a neonatal death, and they actually attributed that to a lack of assertiveness in a neonatal student. And basically they had raised concerns but nobody listened. So they do a lot of work on assertiveness. And you may have heard about the Elaine Bromley case, and she was a lady that had a sinus problem and was a failed intubation and subsequently died. And they actually reenact that, so you can see the Elaine Bromley video that the National Patient Safety Agency have done. But they actually show two nurses. So Elaine went to theatre in her 30s, sinus problem, and all of these anaesthetists and surgeons just kept trying to re-intubate her because they couldn't actually get a tube down. And at the point that her saturations were 70%, bear in mind her kids were 3 and 5 and gone shopping with their dad while she was having this minor surgery. So saturations had dropped, and the nurses there brought a mini tracheostomy trolley in and they booked an ITU bed. And the anaesthetist said, cancel them, we've got this under control. And she never recovered, she never woke from that surgery. But basically what it was saying is you have to be assertive, you have to challenge. It doesn't matter if you're the healthcare support worker, you're the district nursing sister, or you're the consultant, you have to challenge. And there are cases where nurses knew but nurses weren't listened to, and we have to make sure that we're listened to. And that's not being abusive, it's not shouting somebody down, it's having a clear voice, putting your neck on the line. And I think we do that for our patients quite regularly, don't we? We'll go and argue with the GP and say you need to visit, you need to review, but we're less likely to do it for ourselves, you know, and I think it is really important. So I love that statement, and I think it's really important to take that forward. And that's my last slide, so I don't know if anybody has any questions. I didn't make you laugh, I know, and it's probably not as fun as some of the others, but I think they're really